I think we are late and we have to start now this session, which is about crossing of the borders with innovative techniques. And the first speaker in this session will be Professor Philipp Paprotka from Germany. He is a German friend to Egypt, and I think this is the second time for him to be here in Cairo, and he will speak about radioembolization in colorectal cancer. Yes, please.
Dear Chairman, thank you very much for your kind introduction. Dear ladies and gentlemen. In very general terms, the main categories of treatment available for human cancer include, of course, surgery, chemotherapy, radiotherapy, and in more recent time, biologic treatments. But for liver cancer, the situation has historically been surgery and chemotherapy, and now radiotherapy, because the normal liver tissue is very sensitive to radiation as well as the organs nearby. Therefore, those patients have missed very often a highly effective cancer treatment option. To take a look in more detail, you can see here, if you want to treat adenocarcinomas, you need 70 to 90 gray to treat them curative, but even at 43 gray, you have 50% of severe complications. So you will never reach this dose. If you take a look at the blood supply, we do all know that we have a double blood supply of the liver. The normal liver parenchyma is supplied by the portal vein, and on the other side, liver tumors are supplied by the hepatic artery. This gives us the possibility to treat those tumors very selectively by leaving the healthy liver tissue relatively unaffected. If you take a look in more detail, if you inject those spheres are floating through the hepatic arteries into the tumors, and they are very small. If you compare the size of such a microsphere to a red blood cell, you will see it's 30 microns compared to 7.5 microns. So that means they're small enough to float through the hepatic arteries deep into the liver tissue and the tumor tissue, but they cannot go through the terminal arteries. So the spheres become permanently implanted within the tumor. Is it really as you have seen it in the video? Yes, it is. If you take a look at the specific gravity of the resin microspheres, thank you. In comparison to the red blood cells, you will see the red blood cells, you will see that the specific gravity is the same, and so they are very well suspended within the blood, and so the distribution over the whole liver and the whole tumor is very good. If you take a look at the resin heart, those spheres become implanted into the terminal arteries, and not only 3 of them, like 50 to 100 in each terminal artery. And these yttrium layer, they covered this, the yttrium is covering the spheres, has a median penetration of the beta radiation by 2.5 millimeters in soft tissue and a maximum of 11 millimeters in soft tissue. That means that the tumors are treated with high doses while the normal hepatocytes are almost not treated. And it's not only one, these are 100 and 1,000 and millions, 30 to 40 million spheres, and this is called the distribution optimized crossfire effect, and this is why the treatment is so successful. It's not only working in a demonstration. Here you can see a result. This is a histological slide. You can see those black dots. These are spheres within the slide, and all the white tiny spheres are in slices further to the front or to the back, and therefrom you can calculate Igiloc clouds. That means within the blue line you can see you have doses of 3,000 gray, and you have a small decrease or a big decrease, even 4 millimeter outside the tumor, to 100 gray. So you treat the tumor and not the healthy liver tissue. So we are treating patients since 2002, but we haven't been the first by far. The New York surgeon was a lot faster. He started to treat patients with colorectal cancer in 1964, and he had quite good results. So he could triple the lifespan in asymptomatic patients to an average of 26 months in comparison to this historic control group. but he had to stop. And why he had to stop? It was because of the complications. So bone marrow toxicities, radiation gastritis, hepatitis, pulmonalis fibrosis, and so they couldn't go any further. This is one of the reasons why we are so a little bit scared of the randomization, and we do a quite big workup to prevent any problems. So in our department, we have, for the initial consultants, we review all the images, the PET-CTs, the CTs and MRI scans. We do the dose calculation very carefully based on the liver volume and also on the tumor liver involvement, and take a look at all the blood samples. Then we perform a workup procedure where we perform our hepatic angiograms, or we can see here our dynacities, which is more precise. And then we inject the technetium into the right and left hepatic artery and access the liver lung shunting afterwards. On the treatment procedures, normally 1 to 2 weeks later, we perform a prophylactic occlusion, or we recommend a prophylactic occlusion of the extrahepatic vessels. More precise, it's coiling on demand, that we close all the vessels, being a risk for the treatment. Afterwards, the xenospheres are injected, and the SPECT-CT is confirmed to see the correct emplacement. Normally it's easy, it's one therapy position in the right liver and one on the left, but if you combine it with different high-risk vessels like the gastroduodenal artery and with difficult atypical hepatic blood support, then it's getting sometimes a little bit complicated. The only thing you have to make sure is that the spheres are going into the liver and nowhere else. Colorectal cancer, these are hypovascular tumors, so how does it work? How should it work? When we became our robotic system, the Zigo, and the possibility to perform dynacities, I started to understand that it's a little bit different than we thought in the beginning. So this is dynacity, this is our Zigo, so our catheter is lying within the hepatic artery, and the contrast agent is directly injected into the hepatic artery while the dynacity run is performed. And if you take a look at those pictures, this is a normal hepatic angiogram, and this is a normal CT slide, arterial face. You can see that you don't have any enhancement of the tumors. But if you take, in the same patient, a look at the dynacity, where the contrast agent is applicated into the hepatic artery, you see that those tumors are hypervascular, and they must be hypervascular because they need the blood to grow. And this is, of course, the same in the left hepatic artery in the same patients. Here in the CT scan, it looks quite hypervascular, but there's a lot of blood supplies coming from the hepatic artery, even in colorectal cancer patients. This was the next step for me. That is called the DYNA PBV body, peripheral blood volume body. So here is a software where you can calculate the blood volume within the tumors itself. And what we can see here, as an example, you have an MRI scan, the arterial face and the venous face. We can see that these tumors seems to be totally hypervascular, and we wonder how we should treat these patients. Even in the angio, we cannot see really a tumor blush. But if you take a look at the PBV body scans, you'll see here coded in red that you have the highest blood volume within those tumors. That means the resistance within a tumor for the blood is lower than the normal liver, and that means more blood is flowing through the tumors. Maybe we don't have the right imaging to image it with the MRI on the CT. In the dynacity, you can see that. Let's talk about the cost, some guidelines and actual studies. Of course, it's not a cheap treatment, but if you take a look at the quality-adjusted life years, you will see that the spheres are 31,000. These are German numbers. If you compare it, for example, to sorafenib, you're 90,000. So when I'm talking to interventional radiologists, they're always saying, oh, it's so expensive, and the oncologists in Germany say, oh, that's cheap. So it's maybe sometimes different how the people feel about the cost of a treatment. Since 2014, the resin microspheres for treatment of colorectal cancer has been included into the European Society of Medical Oncology guidelines for colorectal cancer. And this for a good reason, because we have many studies showing the benefit of the resin microspheres in comparison also to highly aggressive biological treatments over the last years. But these are all results in a salvage situation. What is coming next? There are many, many ongoing studies at the moment dealing with the randomization in different tumors and at different stages of the disease. And I think you've heard about this or read about this. There was a lot of trouble over the last 2 months. The Igiloc study. It was a study was dealing with adding Zeospheres to the current systemic Folfox treatment plus minus bevacizumab, and this is the largest randomized controlled multicenter study with over 500 patients. Here you can see what they did. So they choose chemotherapy-naive patients with non-resectable liver metastases from primary colon cancer, and they stratified regarding the degree of liver involvement, institution, the usage of bevacizumab, and then they had 2 arms, one without only Folfox and bevacizumab, and one with Folfox and bevacizumab plus Zeospheres. If you take a look at the plan, so the Zeospheres were normally implanted on day 3 and 4 of the first cycle, and afterwards first 60 milligram per square meter, and after the third cycle 85 milligram per square meter, and sometimes plus, sometimes minus bevacizumab. The result of this study was quite not surprising. The primary result, the study did not meet the primary endpoint. This is what was causing the trouble. Igiloc does not show any statistical significant improvement in the overall progression-free survival. Overall means also lung metastasis, brain metastasis. It is really surprisingly, I would say no. But what we could have expected, Igiloc does show statistically significant improvement on the progression-free survival in the liver, which I would expect for a liver-direct therapy. These are the results. The final results are presented in exactly 1 week and 1 day, and these are the preliminary results. We can see that we have a significant higher improvement of the median overall survival or progression-free survival within the liver by 7.9 months. And we have a risk reduction of 31%. And the overall response rate was also significantly better for the Zeospheres plus resomicrosphere group, and even the complete remission part was 3 times higher in the resin group. If we take a look at the toxicity, there were differences between the 2 groups which were not significant. A little bit higher toxicity for the combination of Zeospheres plus resomicrospheres. So in conclusion, these data are very encouraging. We have to wait a little bit further for 1 week until you have the final data sets, and I'm quite excited. What is even more important, there are coming more studies dealing with this topic and not with the progression-free survival in the liver or somewhere else. They are dealing with the overall survival. And there's coming up the Foxfire study comparing new biological agents with or without Zeospheres. There's coming up a Foxfire global study also with the overall survival as the endpoint, and several more studies dealing with colorectal cancer, resomicrospheres plus minus several chemotherapy lines. I think at the moment we are trying to find out which patients really have a benefit of an additional radioembolization treatment and have a prolongation of the overall survival. This is all ongoing study, and at the moment the best evidence we have is for the salvage situation, but I think we will hear more about early treatments in the next years. So to conclude, colorectal cancer, liver metastasis in a salvage therapy, we have a high-grade level of evidence. So we have 2 phase 3 studies, 7 cohorts, 2B and 1 2A. It's demonstrated that the cost effectiveness is quite good in those patients, and it is already included in the European Society of Medical Oncology guidelines for colorectal cancer. The first final results are awaited in 8 days, and 2 more phase 3 studies, more than 1,000 patients are running, and I'm really looking for the overall survival data, because I think this is the benchmark we should hit. Thank you very much.
Thank you, Philip. And I think by the end of the session we will